You know that feeling when you're trying to understand something important about your health, like blood pressure, and it just feels like you're wading through a dense medical textbook, all those numbers and drug names. It can be pretty overwhelming. Well, today, that's exactly what we're going to try and cut through. We are taking a deep dive into the world of medications used to treat high blood pressure hypertension. Really trying to understand what's going on.
Exactly. Yeah. And we've got some really well-structured information here. It's actually designed to give you a solid foundation for understanding these meds. Think of it like a clearer guide maybe to the different drug types, how they actually work inside your body. And, they're really important things to keep in mind. Our goal is definitely to move beyond just like knowing the names. We want to actually grasp the mechanisms.
Right. So the idea is by the end of this, you'll have a much clearer picture. Why certain meds are used, what the key implications are. Okay, so let's start right at the beginning. What exactly is high blood pressure? Hypertension.
So in simple terms, hypertension is when your blood pressure reading stays consistently higher than 120/80. That's millimeters of mercury, or mmHg. What's really interesting, though, is that for most people, like the vast majority, maybe 90 to 95%, it's what we call primary or essential hypertension. And that just means there isn't one specific identifiable cause we can easily point to. It's often, more complex.
So it's not usually a symptom of something else then?
Not in most cases, no. Then you have what's called secondary hypertension. That's the smaller chunk, maybe 5 to 10%. And that type is caused by other underlying health issues. Things like kidney problems or maybe endocrine system disorders. But either way, it's really crucial to manage it because if hypertension goes uncontrolled, it can lead to some pretty serious problems down the line. Heart failure, stroke, kidney damage. So understanding how to treat it is vital for long-term health.
Yeah, absolutely. And those two numbers, 120/80, you hear them all the time at checkups. Can you break down what they actually represent?
In the body. Sure. So when you get your blood pressure taken, that top number, that's the systolic blood pressure, or SBP. You can think of that as the pressure in your arteries when your heart muscle contracts, when it pumps the blood out. The bottom number is the diastolic blood pressure, DBP. That's the pressure in your arteries when your heart is actually resting between beats. We also sometimes talk about pulse pressure. That's just the difference between the systolic and diastolic. And then there's mean arterial pressure, MAP. That gives you sort of an average pressure during one whole heartbeat cycle. There's a formula for it, diastolic plus about a third of the pulse pressure. But the main takeaway is that below 12/80 is generally considered normal.
Okay, so consistently above 120/80, that's the marker for high blood pressure, and definitely something to take seriously. Right, let's get into how we manage it then with medication. I understand there are some drugs doctors usually start with. The first choices?
That's right. We call them first-line antihypertensive drugs. These are basically the classes of medications that have generally shown good results, effective and safe for most people starting treatment. There are 4 main categories you'll probably hear about most often. ACE inhibitors, that's angiotensin-converting enzyme inhibitors. Then ARBs, angiotensin-acetylcholine receptor blockers. Calcium channel blockers, or CCBs, and thiazide diuretics.
Okay, 4 big ones. Let's tackle those ACE inhibitors first. What are they doing?
Right, ACE inhibitors, or ACEIs. You'll often recognize them because their names end with april, like captopril or enalapril. What's really neat about them is how they work. They actually block an enzyme called ACE, angiotensin converting enzyme. Now, this enzyme, ACE, is really important in making a substance called angiotensin II.
And angiotensin II, what does that do?
Well, angiotensin II is a very potent vasoconstrictor. Think of your blood vessels like hoses. A vasoconstrictor squeezes those hoses, makes them narrower.
Right, which increases the pressure inside.
Exactly, your blood pressure goes up. And angiotensin II also signals your body to release a hormone called aldosterone. Aldosterone makes you hang on to more sodium in water, which also adds volume and increases pressure. So by blocking that ACE enzyme, the ACE inhibitors mean you make less angiotensin II. The result: vasodilation, those hoses relax and widen, and less aldosterone. Both help lower your blood pressure.
Okay, so they're basically interrupting a key step in that whole pressure-raising process. Makes sense.
Yeah.
Are there common side effects, things people should be aware of with ACE inhibitors?
Oh, absolutely, yes. Probably the most well-known one is a persistent dry cough. The thinking is that ACE also breaks down another substance, bradykinin. When ACE is blocked, bradykinin levels can go up, and that seems to trigger the cough in some people.
Oh, okay.
Other potential issues can include swelling, we call that angioedema, and sometimes high potassium levels in the blood, which is hyperkalemia. And really, really important, ACE inhibitors are teratogenic. They can harm a developing fetus, so they absolutely shouldn't be used during pregnancy. But, it's not just about blood pressure. They're also really useful in other conditions like heart failure and for protecting the kidneys in people with diabetes, what's called diabetic nephropathy. In those cases, they do more than just lower blood pressure. They offer specific organ protection, like reducing pressure inside the kidneys filters.
Okay, so very effective, good for other things too, but that cough, that sounds like a pretty noticeable side effect for some. Now, what about the ARBs? Angiotensin receptor blockers. They sound like they target the same system.
They do, yeah, they're closely related. ARB is angiotensin II receptor blockers. Examples are drugs like losartan, valsartan.
Yeah.
Their names often end in sartan. So instead of blocking the ACE enzyme like the inhibitors do,
They block something else.
they directly block the receptors that angiotensin II normally binds to. These are called ATO receptors. Think of it like this. Angiotensin II is the key, and the ATO receptors are the keyholes on your blood vessel walls. ARBs basically plug up the keyhole, so even if the key, angiotensin II, is floating around, it can't unlock the door to cause vasoconstriction or aldosterone release. The end result is pretty similar to ACE inhibitors, though. Vasodilation, less aldosterone, lower blood pressure.
Right, so different point of attack in the same chain of events. So what's the main practical difference then? Why choose an ARB over an ACE inhibitor or vice versa?
Yeah, the biggest difference, practically speaking, often comes down to that side effect profile, specifically the cough, because ARBs work downstream from ACE and don't directly affect bradykinin breakdown in the same way.
The cough is less likely.
Much less likely, yes. The risk is significantly lower. So very often, ARBs are used as an alternative for people who just can't tolerate that dry cough from an ACE inhibitor. Both classes are great for hypertension, heart failure, kidney protection. But that lower cough risk makes ARBs a really valuable option if the ACE cough is a problem. It's usually about tolerability.
That makes perfect sense. Similar benefits, but potentially easier to take for some people if the cough is an issue. Okay, let's move to the next group. Calcium channel blockers. CCBs. How do they fit into the picture?
Okay, calcium channel blockers, or CCBs. Examples include drugs like amlodipine and nifedipine. These work by, blocking calcium from entering certain types of muscle cells, specifically the smooth muscle cells in the walls of your blood vessels, and also muscle cells in the heart to some extent. Calcium is actually essential for muscle contraction, so if you block its entry...
The muscles can't contract as strongly.
Exactly, they relax. So in the blood vessels, this relaxation causes them to widen vasodilation again, and that lowers the resistance to blood flow, bringing the pressure down. It's like easing the tension in the vessel walls, but through a totally different mechanism involving calcium channels.
Okay, interesting. So another route to relaxing blood vessels, focused on calcium this time. What about the last of the big four? Thiazide diuretics. These get mentioned a lot too, right?
Yes, they do. Thiazide diuretics. A very common one is hydrochlorothiazide. You'll often see it written as HCTZ. Their main job is to make your kidneys excrete more sodium, and water follows the sodium out of your body and into your urine by reducing the total amount of fluid circulating in your bloodstream.
Less volume, less pressure.
Precisely. It directly leads to a decrease in blood pressure. They're very commonly used, especially as a first step for mild or moderate hypertension. Simple mechanism, quite effective. But like all drugs, they have potential downsides. A key thing with diuretics, including thiazides, is the risk of throwing off your electrolyte balance, like causing low potassium levels, for instance.
Right. Getting rid of water and salt might mean losing other important stuff too.
Okay.
So those are the main first-line players. But what if one drug isn't quite enough? Is that when doctors start combining them?
Exactly. Yeah, very often a single medication won't get the blood pressure down to the target level. Or sometimes using lower doses of two different drugs can give better results with fewer side effects than a high dose of one. So combination therapy is really common. And there are certain combinations that work well together and are generally considered safe. For instance, combining an ACE inhibitor with a thiazide diuretic is a very standard approach. They tackle blood pressure from different angles.
Okay.
Or combining an ACE inhibitor or an ARB with a calcium channel blocker. That's another common and effective strategy. But importantly, there are also combinations you generally want to avoid. Well, using an ACE inhibitor and an ARB together usually isn't recommended. It doesn't tend to add much extra blood pressure lowering, but it does increase the risk of side effects like high potassium or kidney problems. Also, combining beta blockers with certain types of calcium channel blockers, specifically the non-dihydropyridine ones like verapamil or diltiazem, can sometimes slow the heart rate down too much.
Yeah, that's really critical to understand. Not all combos are good. Some can actually be harmful. Good point. Now, we've focused on these first-line drugs, but I know there are other classes out there. Can we briefly touch on some of those?
Absolutely. While those four groups are often the starting point, other classes definitely have their place, maybe for specific situations or if the first-line drugs aren't cutting it. Beta blockers, for example. Drugs like atenolol, metoprolol, names often end in olol. These work by blocking the effects of adrenaline, basically, on beta receptors, mainly in the heart. This slows down the heart rate and reduces how forcefully the heart pumps, which lowers cardiac output and consequently blood pressure. But beta blockers aren't for everyone. They have important contraindications, especially for people with asthma. Blocking beta receptors can sometimes cause airways to constrict, and they're also avoided in certain types of heart rhythm problems, like heart block.
Right, so definitely need to consider other conditions there. What else?
Then you have loop diuretics. Furosemide is the classic example. These are really powerful diuretics, great at removing excess fluid. While they do lower blood pressure, their main use tends to be more for managing significant fluid overload, like the edema you see in heart failure, rather than just routine hypertension on its own. And like other diuretics, they carry that risk of electrolyte problems. There are also potassium-sparing diuretics, like spironolactone. Their main role in managing blood pressure is often to counteract the potassium loss that can happen with thiazide or loop diuretics, so they might be added on for that reason. And finally, a group called vasodilators, drugs like hydralazine or sodium nitroprusside. These work directly on the smooth muscle in the blood vessel walls, causing them to relax and widen very effectively. Sodium nitroprusside, especially, is given intravenously and is super important for emergencies, like really severe, sudden spikes in blood pressure, what we call a hypertensive crisis.
Hypertensive crisis. That sounds really serious, like a true emergency. How is that handled?
It is, absolutely. A hypertensive crisis is defined by dangerously high blood pressure, think systolic over 100 or diastolic over 120, plus evidence that vital organs are being damaged because of it. Brain, heart, kidneys. It needs immediate medical attention, usually in a hospital, and requires rapid lowering of blood pressure using IV medications. Drugs like IV nitroprusside work very fast, but you have to monitor carefully because it can potentially lead to cyanide toxicity with prolonged use. Others commonly used are labetalol, which is interesting because it blocks both alpha and beta receptors, and nicardipine, which is an IV calcium channel blocker. The goal is to bring the pressure down quickly, but also safely and controllably.
Definitely sounds like a situation needing expert, careful management. Now, we've touched on this a bit, but are there specific groups of people or situations where the choice of blood pressure drug is particularly important, where some are preferred or definitely avoided?
Yes, absolutely. Tailoring the drug choice to the individual is key. You always have to consider the whole patient picture, especially other medical conditions or comorbidities, like pregnancy is a big one. Protecting both the mother and the baby is paramount. So drugs like methyldopa or certain CCBs like nifedipine are often the preferred choices, whereas ACE inhibitors and ARBs are definite no-goes because, as we said, they're teratogenic and can harm the fetus.
Right, critical difference there.
For patients who also have diabetes, ACE inhibitors and ARBs are often favored. Why? Because on top of lowering blood pressure, they have that added benefit of protecting the kidneys, slowing down diabetic kidney disease. Although with thiazide diuretics and diabetes, you might need to be a bit more cautious, maybe use lower doses, as higher doses can sometimes mess with blood sugar control a bit.
Okay.
And for someone with asthma, calcium channel blockers are generally a safe bet, but you'd usually want to avoid beta blockers because, again, blocking those beta-2 receptors in the lungs could potentially trigger asthma symptoms or make them worse.
That really drives home the point, doesn't it?
Yeah.
It's definitely not one size fits all. A patient's other health issues are hugely important in picking the right medication. What about things beyond medication? Lifestyle changes always seem to come up with blood pressure.
Oh, absolutely crucial, yes. While medications are often essential, lifestyle modifications are incredibly important too. They're foundational, really. These changes can help prevent high blood pressure in the first place, and they definitely help manage it better, often allowing people to use lower doses of medication, or sometimes even avoid meds altogether if the pressure isn't too high. We're talking about things like maintaining a healthy weight, definitely cutting back on sodium or salt in the diet.
Exercise.
Regular physical activity, yes. Limiting alcohol consumption. Quitting smoking, that's a huge one for overall cardiovascular health. And finding healthy ways to manage stress. These non-drug approaches can make a real measurable difference in blood pressure and heart health overall.
So it sounds like the best approach is often a combination medication when it's needed, plus really committing to those healthy habits. Okay, to kind of wrap things up here, if you had to boil it down, what are the main takeaways you'd want someone listening to remember from this deep dive?
Yeah, I think the key points are, first, managing hypertension is usually a lifelong process. It typically doesn't just go away. Second, the best medication choice is very individual. It depends heavily on your specific health profile, other conditions you might have, things like that. And third, it's really important to be aware of potential side effects. All drugs have them. So you need to know what to watch for. We mentioned the cough with ACEs, maybe potassium issues with ARBs or diuretics, and talk to your doctor about anything concerning. Ultimately, it's about teamwork between you and your healthcare provider to find the right plan and stick with it for long-term heart health.
Okay, so just recapping the big drug classes. ACE inhibitors, ARBs, calcium channel blockers, thiazide diuretics are often the first go-tos. They all work in different ways to lower blood pressure, and picking the right one or combination really depends on the individual person. It's definitely more complex than just grabbing any pill off the shelf.
Absolutely. And hopefully understanding these basics gives you a bit more confidence, makes you feel more informed, whether it's about your own health or maybe helping someone you care about navigate this.
This has been incredibly helpful, really clarifying. Thank you.
Yeah.
So considering all these different ways the drugs work and how complex our bodies are, thinking beyond just the medication itself, what other factors do you think play the most significant role in managing blood pressure and keeping our hearts healthy in the long run? What else should people really focus on?